Good afternoon. I'm Benjamin Haynes, Director of CDC's Division of Media Relations. Thank you for joining us as CDC launches the Hospital Sepsis Program Core Elements, a new initiative to provide hospitals with a blueprint to save lives from a medical emergency known as sepsis. Before we begin, for those of you watching via YouTube, we are providing closed captioning, so please use the feature at the bottom of your screen to have access to those functions. Reporters, just a reminder, we will take your questions at the end of the briefing. Please use the raised hand feature and be sure to enter your name and outlet as your name on the Zoom meeting. You can do this by right-clicking on your name and using the rename feature in Zoom. Now let's begin the briefing. I am joined by several speakers to illustrate the critical need for a highly organized and high-quality sepsis program in all hospitals. You will hear from Dr. Raymond Dantes, CDC Medical Advisor and one of the primary developers of this new initiative. Also with us is a sepsis survivor, 15-year-old Alice Tapper, and her mom, Jennifer, who will share their story of a race against the clock to beat sepsis. We are also joined by the American Hospital Association's Senior Vice President and Chief Physician Executive, Dr. Chris D'Arienzo, who will talk about the value of sepsis programs for every patient in every U.S. hospital. But first, I'd like to introduce CDC Director, Dr. Mandy Cohen, for opening remarks.
Well, hello. Thanks, Ben. Thanks, everyone, for joining today. First, want to thank Alice and Jennifer Tapper, Dr. Prescott, Dr. DiLorenzo, Dr. Dantes for all of their important contributions to this work. And thank you for joining us today as we talk about sepsis. Now, we know anyone can get an infection, and almost any infection, including COVID-19, flu, RSV, can lead to sepsis. We know that sepsis is when an infection triggers a chain reaction through our body, and urgent medical care is necessary to prevent organ damage and even death. We all need to know the signs and symptoms of sepsis. Survival and recovery depends on quick action on the part of family members and caregivers, as well as hospital staff. I know this firsthand. My mom would have died of sepsis nearly 20 years ago, if not for the incredible medical team at the hospital that responded to her emergency. CDC studies tell us that sepsis, nearly 87% of sepsis patients are brought to the hospital with an infection that's really just not getting better. In a typical year, 1.7 million adults in America develop sepsis, and at least 350,000 adults unfortunately die during their hospitalizations or are moved into hospice care. The care of patients with sepsis is complex, and I will say that as a physician who has cared for those patients. It requires rapid coordination between multiple hospital departments and disciplines to respond and then manage the recovery of the patient. We know that programs dedicated to the care of patients with sepsis have been successful in saving more lives, reducing the amount of time patients need to stay in the hospital, and cutting healthcare costs. The bottom line, CDC believes sepsis programs in every hospital, regardless of size, location, and resources, can strengthen the quality of care delivered to these patients and ensure their survival. That's why CDC developed the Hospital Sepsis Program Core Elements to put providers in the best position possible to deliver effective care for patients with sepsis. Here's what was reported through one of our national surveys about U.S. hospitals. That survey showed that about 73% of hospitals had a sepsis team, which is good, but only about 55% of those team leaders are provided with dedicated time to manage those sepsis programs. And only about half of the hospitals reported that their teams integrated their antibiotic stewardship experts into those sepsis programs. So more work to do here. Based on these findings, we know there's an opportunity to improve the support and structure of sepsis programs in hospitals across the country. And CDC is ready to help hospitals measure the success of their programs as they implement these core elements through our National Healthcare Safety Network. Before I go and leave it to the experts here to talk more about sepsis as well as this program for core elements, I want to remind you that many infections can lead to sepsis, and they are also preventable infections. Earlier, I mentioned COVID-19 or flu or RSV could cause infections and could cause sepsis. And we know these illnesses are starting to circulate right now. Please consider vaccination. It is one of the best ways to reduce your risk of infection, protect yourself and your family. And when you reduce the risk of infection, you're reducing your risk of sepsis. Okay, with that, now I'll turn over to Dr. Ray Dantes for more on the fundamentals of the hospital sepsis program core elements. Thank you.
Thank you, Dr. Cohen. From the outset, I would like to thank my colleague and co-lead, Dr. Hallie Prescott from the Department of Internal Medicine at the University of Michigan. The sepsis core elements were developed in collaboration with Dr. Prescott and her team from the University of Michigan and the Michigan Hospital Medicine Safety Consortium. She will be on hand to answer questions at the end of today's briefing. The sepsis core elements are intended to be a manager's guide to organizing staff and making the resources available to improve sepsis care and bring survival rates up. This approach was modeled after CDC's core elements of antibiotic stewardship, which have proven to be an impactful resource to protect patients from the harms caused by unnecessary and inappropriate antibiotic use. The sepsis core elements were created with the expectation that all hospitals and their patients would benefit from this resource. Let's look at each of the 7 elements. The first core element is leadership. Sepsis programs require the necessary human, financial, and information technology resources to be successful. Number 2 is accountability. It's important for sepsis programs to appoint a leader responsible for the program outcomes and to set concrete program goals. Number 3 is multi-professional expertise. Sepsis care spans the continuum of the hospitalization and requires coordination of many services and disciplines. It is critical to engage those key partners throughout the organization, such as the emergency department, the intensive care units, wards, physicians and nurses, specialists, and those caring for distinct populations such as pediatrics or labor and delivery. The fourth core element is action. This core element describes how to implement structures and processes to improve the identification of, management of, and recovery from sepsis. These recommendations complement clinical guidelines for early recognition and early management and provide additional guidance for supporting patients recovering from sepsis. Number 5 is tracking. This core element provides a guide for measuring sepsis progress towards those program goals and the impact of sepsis initiatives. Number 6 is reporting. This core element describes how to provide usable feedback on sepsis care to healthcare providers and usable data to relevant partners. The 7th and final core element is education. This core element describes resources for providing ongoing sepsis education to healthcare professionals, as well as patients and their caregivers. We are very excited to share the hospital sepsis program core elements, and we think hospital leadership and their hospital sepsis champions will find this a useful resource to ensure their staff are able to provide optimal care for patients with sepsis. In a moment, you will hear from Dr. Chris D'Arienzo, the American Hospital Association Senior Vice President and Chief Physician Executive. But first, we have with us Alice Tapper and her mother, Jennifer Tapper. They graciously agreed to share a story of how sepsis impacted their lives not too long ago. I'll turn it over to Alice.
Hello, my name is Alice Tapper. I'm a sepsis survivor patient advocate. I'm a junior in high school and I live in Washington, D.C. I'm very honored to be here. In November 2021, I got sick with severe abdominal pain, a fever of 102 degrees, and vomiting. My parents took me to a hospital where they ran tests and found I had a rapid pulse of 135 and a very white high blood cell count of 20,000. They offered me fluids but could not figure out what was wrong with me. My condition did not improve, so I was transferred to another hospital where I was admitted and diagnosed with severe gastroenteritis. We were told this was a viral infection and that we essentially needed to wait it out. My parents consulted with multiple doctors about what could be done and asked about possible treatments and more tests, but were told that none were needed. At the time, we didn't know enough to ask the question the CDC recommends. Could this infection be leading to sepsis? Over the course of 32 hours, my condition worsened. I was weak in pain and quickly fading away. At one point, my mother begged the doctors to do more for me, but they kept insisting I had a bad stomach virus. I was losing so much weight and could barely stay awake. Luckily, my dad was very persistent and determined. He found a healthcare professional who took additional steps. He made sure I got an x-ray. That led to a sonogram and surgery. I had a perforated appendicitis, and a CT scan showed I had fluid leaking throughout my abdomen. I was rushed to the ICU. I was septic, and the appendix was too inflamed to be removed, and my body was in hypervolemic shock. That's when the heart is unable to pump enough blood to the body, so many organs stopped functioning. My story ends on a positive note, but not before several additional surgical procedures, including getting my appendix out and a long procedure to repair my bowels. I had fully recovered. I'm healthier and stronger than ever and have become a high school athlete. And now I'm on a mission to tell my story and encourage hospitals to listen to patients, even if they are young, and to parents. If appendicitis had been taken seriously and the signs and symptoms of sepsis had been acknowledged, my course of care would not have resulted in weeks in a hospital and a long recovery at home. I missed so much school and so much of my life, and I lost a lot of my trust in adults. Now I'm speaking out for others who do not have a voice. I'm so grateful for the CDC asking to share my story. And a special thank you to Dr. Mandy Cohen. Your leadership on this issue will save lives. I hope others will act fast, and if they see the signs and symptoms of sepsis, and get medical care immediately. Together, we can save lives by listening to patients, families, and caregivers and improving sepsis care.
And my name is Jennifer Tepper, and I'm the proud mother of Alice and wife of Jake Tepper. My heart was breaking, and I was losing my daughter, and I couldn't get anyone to listen. This was my reality one horrible Tuesday night in November 2021, and I never want anyone to go through what we had to go through. My husband, Jake, and I are so grateful that Alice survived. We are also angry that her infection was missed and that she could have died as a result. Patients, families, caregivers, and the medical community need to come together to improve sepsis diagnosis and care. It is not okay that any hospital in the greatest and wealthiest nation on earth missed the signs of and symptoms of sepsis. What we saw our child go through was agonizing. The question we still ask, since sepsis is so common, why was it so difficult to get the urgent care that Alice needed? It breaks our heart to think of the other families that have had similar experiences and those that had different outcome. Since going public with Alice's health struggle, we have heard from dozens of families who suffered because of delayed diagnosis of sepsis, which continues to be a problem. We just heard from another family this summer, a desperate dad reaching out to Jake and Alice on Instagram for help. Every parent should know the signs and symptoms of sepsis. Moms and dads, be on the lookout for one or more of these symptoms: a high heart rate or a weak pulse, fever, shivering, feeling very cold, like cold hands and feet, confusion or disorientation, shortness of breath, extreme pain or discomfort, and clammy and sweaty skin, all of the things which Alice had. Sepsis needs to be addressed. We urge physicians to educate their patients about sepsis, for hospitals to have a well-organized sepsis program that educates their staff on how to identify sepsis, how to coordinate experts from across the hospital for the complex care needed to ensure the survival and recovery of patients with sepsis. If I could turn back the clock, my first words when we brought Alice to the hospital would have been, "Is this sepsis?" Thank you so much. And I want to turn this over now to Dr. Dantes. Thank you.
Thank you, Alice and Jennifer. I'd like to introduce you to Dr. Chris D'Arienzo, the American Hospital Association Senior Vice President and Chief Physician Executive, for a word about the importance and value of hospital sepsis programs.
Thank you, Dr. Dantes. On behalf of the American Hospital Association and our nearly 5,000 members, we are delighted to join with the CDC, Dr. Cohen, Dr. Dantes and his team, and of course, the Tappers, to reinforce the importance of identifying and treating sepsis early and putting patient safety first. Over the years, I've treated many patients with sepsis, and I know firsthand just how hard it is to restore a patient's health once an infection has become severe. But I'm also a dad, and I have 3 amazing kids. And so as both a father and a doctor, Alice, I am so sorry for the experience that you and your family went through. And I thank you so much for the courage in sharing your story to help others. Stories like Alice's remind us that even the most knowledgeable, dedicated, committed, and experienced teams can be surprised by sepsis. That's why the American Hospital Association has been proud to partner with numerous federal agencies in order to support our member hospital and health systems improvement initiatives. Over the years, that has taken a number of different forms, and many of those initiatives have actually helped to affirm the wisdom of the core principles laid out in the CDC's guidelines today. And I'd like to emphasize the importance of just a few of them. First, we know that all of the evidence suggests early identification and early appropriate treatment with antibiotics saves lives. That is easy to say and really hard to do. Why? Because sepsis isn't just one disease. In my specialty's population of sick and extremely premature newborns, the early warning signs of sepsis can look wildly different than those of trauma patients coming out of surgery or of elderly patients in a nursing home. This is why it is crucial to have leadership commitment to supporting the early identification and early treatment programs needed in hospitals. Those active programs need energy, resource, and attention in order to build the kind of standard processes that we know work to improve sepsis outcomes. Remember, sepsis is a complex condition, and its early signs can often be masked when patients have multiple health issues. It is essential to bring together experts from across the hospital in a multidisciplinary approach to build those programs targeted at early identification and treatment. When they're at their best, those programs can look something like hospitals' other code teams. And the best code teams that I've been a part of often function like a well-oiled NASCAR pit crew. But as has already been pointed out, much more eloquently than I could say it, the most important members of that crew are in fact our patients themselves and their loved ones. In addition, we are blessed to live in a time of technological transformation. It's hard to believe that when Dr. Cohen and I started our careers, we were lugging huge paper charts around hospitals. Those days are gone. And today, not only are those records electronic, but artificial intelligence companies are combing those records in real time to help doctors, nurses, advanced practice providers, and other healthcare professionals identify patients at risk of sepsis even earlier. We must continue to support those innovative approaches to care with the resources they need to be successful if we are ever going to be successful in our efforts to stamp out sepsis. And finally, we must do everything we can to break down barriers that exist to getting patients identified as early as possible and treated as early as possible. The evidence to do so is clear, and it saves lives. And that's why at the American Hospital Association, we've also been clear that policies that some insurance companies have, which are one-size-fits-all, retrospective in nature, they just miss the mark when it comes to early identification and treatment. Again, thank you so much to the CDC for focusing on this issue. We know it is crucial to improving sepsis outcomes. Thank you for inviting the American Hospital Association to join today's conversation, and I really look forward to the questions.
I'd like to thank all of our speakers. And before we take the first question, I want to note that unfortunately, Dr. Cohen is not available to join us for the question and answer session. However, Dr. Hallie Prescott is with us as well to answer questions about the development of the sepsis core elements. Again, just a reminder, for reporters, please use the raised hand feature and be sure to enter your name and outlet as your name on the Zoom meeting. You can do this by clicking on your name and using the rename feature in Zoom. Now let's start the question and answer session. While we're waiting for the first question, I want to just provide an opportunity for any of our speakers to provide any final thoughts or comments that they didn't address in their comments. Okay. Dr. Dantes, I have a question for you. Was there an increase in sepsis during the pandemic, and do you foresee any increase during flu season?
Thank you for that question. I was actually in the middle of typing the answer there. So there's a little bit, just to clarify, when folks come into the hospital with influenza or COVID-19 and they're very sick, that is a type of sepsis. And so if you're, so that in itself, kind of increases the number of patients coming into the hospital with a type of sepsis. Sometimes this question can also, mean, did we see other types of sepsis also, increasing during flu season? And I think looking back, retrospectively over the years, we do see a seasonality with other types of sepsis as well, that it does tend to increase during the winter months.
Thank you. And we have a clarifying question here from Modern Healthcare. Who are the relevant partners that hospitals should report sepsis outcomes and other information to?
Thank you. Yes, I think I was able to address that question in the answer, but we kept that text very broad. But we do know that many hospitals report on their sepsis care to federal partners, such as CMS for the SEP1 measure, or to state partners as well, or they may belong to quality initiatives where they try to share best practices, like the Michigan Hospital Medicine Safety Consortium, for example.
Thank you.
Ben, I'd be happy to add to that answer as well.
Please do.
I think one aspect of the CDC's sepsis core elements that we really appreciate is they don't put forward a one-size-fits-all approach. And we know that sepsis is complex. And when I look across the spectrum of hospitals and communities in this country, the core elements allow our hospitals to build a program that fits their community. I've practiced in large centers and in some very small centers. And the kinds of partners both inside the hospital and across systems that can certainly vary depending on the community that you're in. The commitment, however, does not vary. The commitment that I have seen both as a practicing physician, as a health system leader, and now at the American Hospital Association is very strong.
Thank you. Reminder, if you are a reporter looking to ask a question, please remember to raise your hand so that we can see you in the queue. While we're waiting, I have a question for Hallie Prescott. Why is sepsis so difficult to identify? You would think in an emergency room, it would be widely suspected.
Yeah, thanks for that question. It's so important. I think one of the challenges is that sepsis can look very different across different people and can also kind of overlap with other types of conditions. So, earlier there was sort of noted a bunch of different symptoms that should certainly sort of raise alarm bells and raise flags. But unfortunately, there's just a lot of variation. So it really always needs to be at the forefront of everyone's mind. It's important to remember that question of, could this be sepsis? We wish we had sort of, one blood test or one diagnostic test that could just say, yes, this patient has sepsis, or no, they don't. But we just don't have that. So it does really require a holistic assessment of the patient's clinical presentation, as well as their presenting testing. Thanks.
I'm sorry, let me say that one more time. In these days of strained hospital budgets, is there any concern about hospitals having the financial resources to put together a sepsis team? Is there any estimate of how much these teams might cost?
I can
take that question to start. Oh, sorry, did you?
Oh, you can go for it, and then I can chime in if there's any more to add.
Sure. Sorry about that, Hallie. So as Dr. D'Arienzo emphasized, the sepsis core elements are not a one-size-all-fits plan for hospitals. In fact, the accompanying MMWR article that is coming out today, shows that 73% of hospitals have already assigned, a leadership committee to sepsis, and about half of the hospitals have already made this someone's position, to at least on some kind of a portion of their job title is to manage sepsis, in their hospitals. So hospitals have already committed resources to this. I would argue that sepsis is a critically important outcome for hospitals, and they should be dedicating those resources. But again, as Dr. D'Arienzo emphasized, this is not a one-size-all plan. There are some large hospitals that are going to need considerable resources to be able to keep track of sepsis, and many already have dedicated those resources, but that would look very different, at a very small hospital. I'll turn it over to maybe Hallie or Dr. D'Arienzo for further comments.
Yeah, I agree with everything that Dr. Dantes just said. And also, I think, we tried to build in a lot of flexibility in terms of how these might be implemented. And I think certainly for some hospitals that are part of a larger healthcare system, some of the work can be done across the entire health system to try to conserve resources. But like Dr. Dante said, this is something that already hospitals have invested in, and we want to make sure that that investment is doing the most that it can. And this is also just an incredibly important topic, as was mentioned by Dr. Cohen. Sepsis contributes to 1.7 million hospitalizations annually, and accounts for over 1/3 of all U.S. hospital deaths. So it's a very important topic that is certainly worthy of resources, and we want to make sure that hospitals are doing the best they can with the resources they have to address sepsis.
I really appreciate Dr. Prescott's note on that front. We know, according to our bond rating agencies, that 2022 was the worst operating year on record for the entire universe of hospitals in America. And so the financial strain noted by that reporter is real. At the same time, I've again seen the commitment to sepsis firsthand. And as Dr. Prescott notes, one of the health systems I worked in had one tertiary referral center and several small hospitals, including critical access hospitals, which are hospitals that are typically in rural areas with less than 25 beds. And because those hospitals were part of a larger system, we could spread the system-wide sepsis campaign into their emergency departments in ways that are much, much harder when hospitals are small and independent and operating on their own. And certainly the financial strain noted doesn't get easier when we talk about the kinds of denials, even relative to sepsis care, that we face from some insurance companies.
Thank you for that. I have one more toss-up question. What information would you want infection preventionists to take away from this webinar specifically?
I could take that question. I was actually also about to type an answer there. So we do want infection preventionists to be to participate in those sepsis committees, because there are, a portion of sepsis patients that develop sepsis in the hospital, and certainly many of the healthcare associated infections that we track can turn into sepsis if they're not caught and treated early.
Thank you. And we have a question from Amanda at CNN.
Hi, can you guys hear me?
Yes, ma'am.
Hi, thanks for taking the question. So just kind of a broader question. Are hospitals expected to implement these new guidelines? Are they encouraged? Are they expected to? And how would you recommend that they do that to the best of their ability, especially smaller hospitals that don't have these sepsis committees?
Sure, I can take that question. So hospitals are definitely recommended to implement parts of the core elements that fit their hospital type and their patient population. We do recognize that hospitals may be starting in a very different place regarding their size and available resources. Towards the beginning of the core elements document, we have a getting started guide, because we know that based on our NHSN annual survey, about 1,400 hospitals are basically starting from scratch. They don't have a sepsis committee yet, and we want to encourage them to go ahead and get started, and we provide that guide to get started. And for those hospitals that have already, got sepsis programs underway and have available resources, we have a lot more details and best practices that we've collected from hospitals about how to further improve your sepsis programs.
I would love to add on to Dr. Dante's answer there. I can't emphasize this point enough. Sepsis is a truly complex condition, and that means that there will likely never be a one-size-fits-all approach to measuring, preventing, treating, or addressing even early identification. That's why the most crucial aspect of these CDC sepsis core elements, I think, for our membership, is the fact that they are flexible and they are a scaffolding around which hospitals of all sizes can build a program that's right for their communities.
Thank you. Our next question comes from Mary Rosenthal at Infectious Disease Special Edition.
Thank you for taking my questions. I was just wondering, I realize that, it's very hard to diagnose sepsis and stuff, but are there groups or particular symptoms that would absolutely be a red flag for sepsis?
That's a tough one. And while I know we have two incredible sepsis experts here who I'll defer on the details to, and in my practice as a neonatologist, sometimes the only and earliest sign of sepsis in an extremely premature baby was a slight drop in heart rate. And so the variability is pretty significant when you look across patient types. Perhaps an elderly patient who comes to the hospital with heart failure and has new shortness of breath. Sometimes it can be really challenging to know whether that new shortness of breath is coming from worsening of their heart failure or of an early sign of sepsis. And so I think it goes back to the earlier notes. Sepsis really is a complex condition, and we appreciate the scaffolding that has been built by CDC around which hospitals can continue to build on our strong foundation of work.
Thank you. Our next question comes from Joyce Frieden. Ma'am, you may ask your question.
Yeah, can you hear me?
Yes, we hear you.
Oh, okay, thank you. You mentioned the number of people that get sepsis and the number of deaths or transfers to hospice. Is there a dollar amount associated with treatment of sepsis?
Dr. Dantes, you want to take a stab at that, or Dr. DeRienzo?
Sure. Yeah, I know there have been many studies looking at the financial burden of sepsis. We haven't done those studies ourselves, so I can't give you kind of a nationwide, estimate. I don't know if Dr. DeRienzo may have a different perspective on that.
I certainly don't have a number either, much less a number that would also impact all of the human toll of patients who experience sepsis and need to get back in the way that Alice described, the challenges that she walked through.
All right. And our last question, Alice, we saved it for you because we appreciate you so much being here telling your story. As a sepsis survivor, if you had one important message for families, peers, and doctors, what would it be?
That people need to have sepsis on their minds. The education of sepsis is so important for patients and their parents because many people don't know what sepsis is. I'll tell my friends about sepsis and they're like, I've never heard of that before, but it is a lot more common than people think. And recognizing the dangers of just the ticking clock of how short the span is when you have sepsis and how bad it can get and how quickly it can get bad.
Mm-hmm. And listening to caregivers and parents and the patients and including teens, because they know what they're talking about too. So I would just say that it's a partnership for everybody involved.
Thank you both for that. That is all the time we have. I would like to thank all of our guests and reporters for joining us today. I'd also like to mention that September is Sepsis Awareness Month, and CDC has an ongoing national educational effort called Get Ahead of Sepsis. To learn more about sepsis and how to prevent infections, visit www.cdc.gov/sepsis. Also, there are two resources that you may want to review featuring sepsis. Today in CDC's MMWR, you will find a CDC study entitled Sepsis Program Activities in the U.S. Acute Care Hospitals. It expands on the statistics we gave you this afternoon, and to complement the MMWR, in JAMA, there is a viewpoint on the development of the hospital sepsis program core elements as well. For additional questions, please contact the main media line at 404-639-3286, or you can email media@cdc.gov. Thank you for joining us, and this will conclude our briefing.